Oh, hey, Chris.
Hey Chuck, how are you?
I'm really good. It's good to be back together.
It is good to be back. It's nice to have some time. I've been looking forward to this weekend the whole week, just because it's been a crazy week.
It has. I definitely want to hear about your week. I think both you and your lovely bride are both really busy this week.
Yeah, we're refreshed. We had a week off and came back and kind of hit the ground running. I somehow paid the penalty for being away with a monster clinic on Monday. Who's our fellows? Adam Mosa is has started with us. He's fantastic, and his first day with me was a monster clinic. So we had our running shoes on all day, and then the week has just taken off from there. And then my wife was chairing a CME course for their specialty, which was yesterday. So it's been busy.
Yeah, we had discussed potentially recording earlier this week on Thursday night, and I ended up in the OR most of the night. And I heard you had a late plexus exit. I thought I was worried about you because you had told me you had to get home in a reasonable hour. And I don't know if all that worked out.
Yeah, it wasn't ideal, let's put it that way. But when the OR moves you to a different pod, I got moved from one part of campus to the other with the promise that the start time would be the same. I knew what was going to happen. My 12:30 start turned into a 2 o'clock start, which means, when you're starting a plexus at 2 o'clock, we got out by 8, which was fine. But it was just a lot of work to do. And, the case moves along really well. And I know that you were coming in to do what sounds like a very challenging case in terms of, a bad wrist fracture dislocation. So we were like ships passing in the night.
Yes, I never even saw it. It was funny. The case was billed as a partial hand amputation, when in reality it was just a really bad, wide open fracture or dislocation of the carpus and distal radius. And it was super fun with the fellows, though, full of energy and full of skill. It was great. It was a great case.
Some birdie told me that there were two fellows scrubbed with you and a third one watching, which is unbelievable. It certainly is the first month of the fellowship
Well,
because mine was actually like around because we were finishing the plexus. I don't know how you nabbed two fellows to join you.
right. So Adam was around and just popped his head in for a little while because it wasn't all that late. And then the other two, I guess, had just been talking, and it was a fairly interesting case. What I love about having three fellows, and what I love about them being collaborative, which almost always they are, is they bring different skill sets. I mean, really different skill sets. And so one of the fellows had a trauma-heavy residency and was just super comfortable with the spanning plate. The other was comfortable, but maybe not quite as comfortable. And they build off each other. And I just try to let it all happen.
Yeah, it must have been nice for you. Must have been nice, but yeah, that's the great part. I think one of the things that I really love about our fellowship is that we attract folks from all over the place, and kind of give them a different experience than what they've seen. But it is fun to watch them learn from each other, and for honestly to learn from them. So yeah, I'm glad that you also seems like have had a good week, although albeit a busy one.
Yeah, I keep trying to cut back clinically. Well, if we can talk about that later. I'm highly unsuccessful at doing that. I've tried different strategies, and it's going to be more important that I do it. But yes, very busy clinically.
Well, why don't we acknowledge our sponsors first before we jump into a potpourri of questions that I have for you, and then we can talk about another fun topic too.
I love it. I love it. The Upper Hand is sponsored by Practice Link Magazine, the physician job search and career advancement resource.
I wonder if people caught that switch up. The
I know.
magazine. Becoming a physician is hard. Finding the right job does not have to be. Join Practice Link for free today at www.practicelink.com.
We'll see. Hopefully, people listen to us and they actually notice.
I don't know, Chuck. I know that sometimes when I listen to podcasts, and if it's like clearly a commercial break, I'm guilty of the 15-second fast forward.
Well, I've done it too, but I think for the podcast I regularly listen to, I don't always do it, especially if it's not going to be a 2 minuter. If it's a 15
Right.
second or so, I feel like it's understandable why there's marketing in podcasts. There has to be.
Are we rationalizing our decisions now, Chuck?
We are. Does the loyal listener know what's coming?
Oh, well, they'll find out soon. Anyway, so I've had some random thoughts that have come up. One of the great parts about being in academics, as many people know, or from being in training too, is that you have the chance to just kind of question your everyday decision making because somebody else, well, why do you do it that way? So especially if you have somebody new working with you who haven't worked with before, So some of these things have kind of come up just not necessarily by our trainees, but I was just thinking about them. So we talk a lot about the adipofascial subcutaneous ulnar nerve transposition. And I think a lot of people like it now. And just kind of by word of mouth, a lot of people have been doing it because I kind of asked people who trained elsewhere what they've seen. So there are a lot of different ways to do it, and we know that Mel Rosenwasser probably published the first article on it with, I think Danoff was the first author. But admittedly, I've modified it to kind of work to what works for me and then what works for that patient's particular habitus. What if the patient's super skinny or slender, Chuck? What do you do? Is that still something where, if it's not one that you would have done a submuscular transposition or an in situ decompression alone, are you still offering that sub-Q transposition with the adipofascial flap, or do you change your technique, or do you go to a submuscular?
I think it's a great question. It's certainly something I've pondered as well. I'll start by saying, in the Midwest, many of our patients have plenty of adipose tissue, and so this is not always a challenge. I could imagine in different parts of the country, it may be more frequently an issue. But I will say that in my population, typical population, which is often adolescent or young adult, there can be a lack of supporting tissue. And certainly in different sports, it becomes even more relevant. So, for example, the volleyball player who happens to be very thin, little tissue subcutaneously, and you really have to think about what the right thing to do is. So here's how I think about it, and I really am curious how you think about it. First of all, I'll say in most patients, there's plenty. And for me, plenty means it's typically more, there's more tissue proximally. And often as I go distally, there's less tissue, and that's okay. I love when the nerve's covered in its entirety with a nice thick bunch of tissue, but it's not always the case. The first goal, if I'm going to use this flap, is to make sure there's enough to keep the nerve anteriorly. And usually I can find that amount of tissue proximally. And sometimes the nerve is a little uncovered distally. In those cases, I do release some of the fascia, so the nerve just lies a little less prominently. Not really an intramuscular, but just sort of that leading edge or the distal edge of the FCU fascia as it dives and splits between the heads. I'll release that. So I'm babbling a little bit, but I would say that in most patients, there's plenty of tissue. In almost all patients, there's proximal tissue. There have been one or two over the last couple of years where I've gone submuscular. I really have just totally switched. I do not like the Eaton flap, the fascial flap that you lift up, because I do think it is more likely to cause scarring. Sorry, that was a mouthful. I love your
That's okay.
thoughts.
No, I think there's a lot of good stuff in there to unpack. But I mean, I guess first the question I'd ask are there any remaining indications for an Eaton flap in your practice?
The only remaining indication would be, and this may be a question we were going to talk about, I don't like submusculars in high level athletes. I just don't believe in cutting the entire muscle mass to go submuscular unless there's a really extenuating circumstance. And so if I had no subcutaneous tissue to work with and I had to keep the nerve anteriorly, I would do some type of Eaton flap. But that I don't really think that situation exists, but I guess it could.
Yeah, I mean, an Eaton flap is obviously a nice thing to use. It's a nice thing to know how to do because you sometimes need to trot it out if you're doing revisions or kind of crazy situations like you described. That's at least the remaining indication for me is just to know when to use it, but it's not certainly not plan A, B, or C. Um, are there any patients that from the jump you say we're not doing a subcutaneous transposition because you're too skinny?
No, but I do in the patients that seem skinny enough, I do talk about the possibility of a submuscular. The nice thing about a submuscular, I'd love your opinion on this. I don't think the recovery is fundamentally different. It's a bigger surgery, but I think the patients rebound just as quickly. And I still, at 6 weeks, I let them, really start making progress. They're really only protected for 4 to 6 weeks in either case. I just fundamentally don't like it as much. So I
So
talk about it
hold on.
more. Mhm.
Two things, in your words, two things. I fundamentally disagree that they are similar surgeries, but I agree with the timeline that you gave for a submuscular. I think they can come back quicker from a subcutaneous, and I think a subcutaneous is a much less painful surgery for the patient. I think the only reason I protect my subcutaneous transpositions now a little bit more than I probably need to is just because the fact that, for that adipofascial flap that you're using to secure the nerve, you're sewing in fat. And I don't want them doing anything aggressive early to disrupt that, which is, I think, probably the only reason why I still protect them. I know that there are a lot of places where they'll do a subcutaneous transposition, maybe with the Eaton flap or something else, and just let them go right away. I feel a little nervous about that. I think that, it'll probably work most of the time, but you might have a patient occasionally who pushes it, because I think you can feel pretty good after a subcutaneous transposition, whereas after a submuscular, you're feeling it, and you're probably not going to do as much pretty quickly afterwards.
So this is interesting. Okay. So what do you do with your subcutaneous? What do you soft dressing or splint? And when do you allow them to really start working on motion?
So I do a plaster long arm splint in the OR, and then I follow pretty much the same protocol that I do for my submusculars right away, which is I have them come back for a first post-op visit, usually 3 to 7 days afterwards. There's no drain usually on these, but at least we have the workflow established where I can get them into a therapy-made long arm splint that they're removing to work on motion, and then they sleep in a cock-up wrist brace, and they don't have to sleep in the long arm splint. And that's evolved over time as I've kind of talked with our therapists. I used to be super protective of them, but essentially they're working their way out of that long arm splint within the first few weeks. And honestly, they usually end up not using it. But I like to send the message that we need to protect something, protect the transposition for a few weeks at least.
I love this. So when you get older, everything's a few years ago. A few years ago, I stopped using a postoperative splint. I use a bulky soft dressing. There is no therapy involved at all anymore, and I have zero regrets. So I used to do something similar to you. I didn't see him back at 3 to 7 days. I was seeing him back at 12 days, but something similar. I have had no regrets for not using a splint at all. The bulky soft dressing seems to work. I've had, knock on wood, no failures of failure of the flap. And I would say in that adolescent population or young adult population, those patients, again, not submuscular, those patients are back to all activities at 8 weeks.
I would agree with the 8 week thing, and it'd be interesting. Maybe in a quote few years, I'll also be doing things that are wiser. What was the impetus to change?
The fact that I felt more and more like most people weren't splinting, and I'm like, well, everyone else seems, to be doing fine. Granted, they always leave the OR with a sling because all these patients get blocks, and so they leave with the sling. So some of them are going to go slower and use the sling and the bulky soft, but I think some of them probably ditch the sling pretty quickly.
Do you let them take the bulky soft dressing off before they hit your office for post-op visit? So is that day 5 or something?
Day 5.
Okay. All
Yeah.
right.
No. Yeah, it's interesting.
That is interesting. I think one question I want to other random thought, because we've talked about this, especially during the pandemic. When do you start to let incisions get wet?
Simple incisions, 3 days. Showers are fine. No soaking, no scrubbing. The little bigger incisions, you could argue incisions heal side to side, not end to end. It shouldn't matter, but like cubital tunnel is typically 5 days, and I'm worried for some reason, maybe 7. As long as they're not splinted, obviously if they're splinted, then that stays on until first post-op visit.
Yeah, it's interesting. I think that when you're a patient yourself, you start to question some of these things. You're like, why can't I not get it wet for a certain amount of time? So yeah, if I'll let my carpals, triggers, and anything light kind of start to get wet at 3 days, dressings down at 3 days. And especially for even the bigger incisions, just with the big like plexus reconstructions and nerve reconstructions, I've started to use a lot more of the skin glued dermabond kind of thing and let them get wet early on, just because not being able to shower, take care of yourself for more than 3 to 5 days is onerous to the patient.
Yeah. I'm gonna say this. I don't think we need to change anything. Am I coming through clearly? Because you're bouncy, like your internet. I assume it's your internet, hopefully not my internet, or hopefully not both of our internets. Do I sound okay to you?
You sound okay. I'm like right next to my extender thing, which is weird. I have really good
Uh,
signal right now.
okay. Well, maybe it'll be fine. Hopefully
Okay.
it'll be fine. Sorry to mess up the flow. I was going to say we were talking
I
about.
can segue into the next part about.
Yeah, let's just do that.
So then, another thing that came up recently is I was doing a case with one of our partners who was doing an ulnar collateral ligament reconstruction, And we were talking about whether I should put the nerve subcutaneous or submuscular. I automatically thought I was going to put it subcutaneous, mainly because I wanted to get it away from all the scarring from the Tommy John surgery. I have a similar approach when, we're doing a capsular contracture release, or one of our partners is doing something for the elbow joint proper. I want to keep the nerve away from all of that inflammation and swelling. Is there ever, in a throwing athlete, one thing came up is that you never want to violate the flexor pronator mass in a throwing athlete. You kind of alluded to that earlier, but, how do you consider the use of a submuscular in that population?
Yeah, I think you kind of mentioned two separate things. One would be the throwing athlete in combination with the UCL, and the other would be a bigger elbow procedure. So I assume you were working with Matt Smith. Matt and I operate together on Wednesdays, and so I do a lot of these with him. And they always go subcutaneously. And again, no regrets. The recovery seems to be uneventful. I've not had the scarring issue. Now, to be very clear, not every UCL needs a nerve. I think those in the sports world understand that. But if they have preoperative nerve symptoms, they are transposed. And I think it's just very helpful for Dr. Smith to have that exposure and have us there. It's not that he can't do the procedure, but I think he feels more comfortable with one of us there. What's more interesting to me, or differently interesting, is an elbow release procedure. And this is typically an older patient who's arthritic, and you're doing a bigger procedure, whether it be arthroscopic or open. But especially with an open, where do you put the nerve? You sort of need a bigger approach to get down to the joint. You go submuscular, where the nerve might belong if the nerve's acting up, and then all of a sudden your nerve is in the joint. So I don't know what to do in that situation.
Yeah, and I like to keep the nerve away from the joint in that situation. And certainly, if somebody's going to be scoping, that's something that they should know about where you're going to put the nerve. But typically, I'll let them scope first to get that out of the way. The problem with having them scope first, just like if you were working on a peroneal nerve at the knee, is that then your soft tissue planes are all distorted, and it becomes very challenging to do a soft tissue procedure. But I tend to keep the nerve away. I'll do these in combination with our elbow surgeons sometimes, and it's just putting it in the best place, which is why you kind of need to know all the tricks and all the ways to do things and think on your feet. At least that's how I approach it.
Yeah, for sure. And I would say if that patient I think it's been interesting to watch the evolution, and I don't want to go down the total tangent, but there is clearly a group of patients that have both ulnar nerve issues and UCL issues. And the treatment of the UCL has really changed. And so sometimes we are exploring together, and it ends up that he doesn't do anything about the UCL, and I just deal with the nerve. Sometimes it's more of an imbrication or internal brace for the UCL, and I deal with the nerve. And sometimes it's a formal reconstruction. And I think all those happen regularly. It's really a fascinating process. And some of this comes with his being quite busy with UCLs, but it's really interesting. I think it's a nice way to team up and work together, which is super fun.
Yeah, it was super fun. It was just a little stressful because I decided this was right before I left on our trip, and I decided to put on, again, we've talked about this on the pod in the past. I put on an extra clinic just to like kind of decompress things, and so I put it on before the trip, and I was trying to do this case at one location before doing a clinic at a different location, and I was like, oh, I'll just get in there, transpose the nerve, and get out of there so he can do the reconstruction. Obviously realized during the case that I needed to be there to finish the transposition after he did the reconstruction. And so I timed things a little bit improperly, and it worked out okay, but it was a little stressful. But that was a self-imposed issue. But anyway, let's pivot to our next topic. I see this with frequency, and it feels kind of taboo. Do you operate on patients with painful Dupuytren nodules?
I think we've talked about this. One thing that's always interesting to me is and thankfully it's rare, you get a really unhappy patient leaving a negative review. You always remember, well, I always know who that patient is, always. And they don't come back because they're so mad. Well, probably the most recent one was a few years ago, thankfully. And there's someone who kept coming in for their Dupuytrens, kept coming in, and had a painful nodule and wanted it excised. And I said, look, I don't like that you're having discomfort. This is not a large nodule. It may calm down. How about we do a steroid injection? And he basically said no, he wanted it excised. And I don't know. I mean, I'm not against surgical excision of painful Dupuytren's nodules. A, it's not really needed very often. B, injections usually do the trick. And C, it becomes, do we kind of give patients what they want? I don't know. What do you think?
So you know, I've come to realize that if somebody really thinks something is painful, if I remember when I was in training, I was a fellowship here, and I remember seeing patients with one of the faculty members at the time, and he was just like, "Look, I give them options, and they can decide." And I think that that works for some patients. It doesn't work for other patients. But if they are coming in with this and they clearly think it's painful, I tell them, "Look, usually we don't have to take these out. Usually these aren't that bothersome. But if this really bothers you, we can take it out. You may be trading a painful bump for a painful scar." You talk about, you always remember the patients who left you bad reviews. I have a patient who had trigger finger released, incredibly happy with the trigger finger part of it, no more triggering, but the scar on that part of the palm was incredibly painful and just never went away. And that's one of my worst negative reviews on wherever health grades or ZocDoc or whatever it is. And of course they leave negative reviews on multiple platforms using the same spiel. But so it I tell them, look, could you be trading a bump for a scar, and the scar might be painful too. There's a chance it can come back. We can't get rid of all the Dupuytren's, and if you want to do it, we can do it. But it's kind of an expensive fix.
I think that's well said, and I agree with the giving options. I mean, sort of that's our role for many patients, like you said, not all patients, but for many patients. It is an interesting phenomenon in the age of value-based care and how the patients may not be truly ready for that, because the issue with the patient I referenced is, it kind of just escalated, and I wasn't sure I wanted to operate on this guy, but patients sometimes have very strong opinions, and when those don't align with us, I generally resolve that internally by thinking, well, if I'm not doing him harm, I'm happy to try to make the patient happy with an excision of a Dupuytren's nodule, for example. But it does get tricky when you're not sure about the real necessity of something like that.
Right. When the eventually the AI model of pre-authorization is going to say no, and they're going to realize that maybe this isn't absolutely necessary and the value isn't there. But again, if somebody says something hurts and they want it out, I treat this was like a lot of like the lumps and bumps that we see in hand surgery. It's like you don't have to have this taken out, but if it really bugs you, we can do it. And part of the nihilist to me wants to be like, well, if I don't do it, somebody else will. Might as well be me. And I don't know if that's maybe a little bit too candid because it's like, well, I can do a good job, and then no, I'll take care of it. So
Yeah, you'll do a good job. You'll take good care of them. They generally are appreciative when the surgery is done. And again, as long as you're not doing something that's potentially harmful, which of course you won't, then I think it's fine. And I haven't, one of our partners, as he has aged, becomes more dogmatic, I believe, and just yes or no. And I don't think I'll ever be that way. I don't think.
all right, you heard it here first. And I do these under, just for completeness sake. I do it under local, and the patients I've done them have been incredibly happy. Mainly after there's a lot of bias. They want to be happy after investing in something like this, and so it's worked out pretty well.
So
Good.
well, let's do one quick discussion. One of the friends of the podcast, Bob Vandermark, emailed, and I apologize, Bob, it's been a little while, about treatment of a college baseball player and the role for hook of the hamate excision in the athlete. When do you potentially treat it surgically, not surgically? Do you ever fix the hook of the hamate? So I think it's a good topic, and if you want to start, I'd love to hear your thoughts.
Well, I mean, this doesn't come my way that often, because of just the nature of the practice. Usually it ends up going to you. I think before we jump into I think the technical parts of it aren't really that tricky or challenging. But I want to hear your spiel about kind of the batting hand and, the how you grip a bat, because I think that that's something that I was never formally taught. And I think, which hand is it, the top hand, the bottom hand? I didn't play baseball growing up, so, it's just something that I always kind of get confused on.
I thought you were a baseball coach now, so you should know this stuff.
Yeah. If anybody saw the coach pitch situation that was happening, you would know that I was not a baseball coach, really. I was just a warm body.
All right, well, that's fair. I'm glad you were volunteering to help the kids.
Help
So
beating them with an underhand throw. Yes, that was me.
So, and again, I think, some of our listeners are not familiar with baseball, but in this country, there's still a lot of people who play baseball. And if you're batting right-handed, your bottom hand is your left hand. And when you swing, you let go with your right hand, and your follow through is all with your left hand. So a right-handed batter primarily holds the bat with his or her left hand. And what happens is all the force from that bat is directly on the hook of the hamate. And so it's a repetitive stressor in that area. There are actually solutions or preventative measures for hook of the hamate fractures, different bat design, etc. Those have never taken off because if you're unlucky, it happens once and then you're done and it's treatable. So it's really an interesting thing, but it's always that bottom hand. It's I say 99% of the time. I guess you can fracture it with a slide or a fall or something, but it's almost always related to batting, and it's always the bottom hand.
What about other sports that involve like rackets or like cricket, for example, if for listeners, from other countries, or like, do you ever see this with tennis or pickleball or anything like that?
No, I mean, I really don't. I see it from falls and I see it from baseball. Theoretically, I think you're right. Cricket is a potential predisposing factor, and I would love it if one of our listeners could clue us in on cricket and which hand is at risk. Don't see it in hockey. So I think it's either a fall or baseball.
Now, what about what kind of the stress reaction, prodromal kinds of things that happen before an actual fracture? Oftentimes I'll see that, pick it up on an MRI, that kind of thing. What do you do about that?
Um, I the first goal is absolutely to rest the patient. I don't have complete faith that that'll cure the problem. But if you have pain directly over the hook of the hamate, exacerbated by swinging, typically an X-ray will be normal. An MRI will show edema in the body and the hook, and you can shut them down and let it rest, and then try to ease them back into baseball. I think they still have a risk of that turning into a fracture down the road.
Do you ever excise the hook before it fractures?
Um, I've had that discussion. I have not done it. Because typically people try to play through this, but I don't think, I wouldn't say it's crazy to do that, especially in the situation where they're not willing to shut it down and take that chance. But I would try not to do that.
And then technically a pretty straightforward surgery. We know it's all about the nerve, but you do your
Always.
Guillain canal release, you free up zone two. How do you, physically maneuver that fragment out? Is it as obvious as it should be in terms of it being a sizable fragment that is quite mobile, or is it a little more challenging than that?
Yeah, I look forward to talking about that. I want your opinion on how to handle the motor branch, but I would say this for me, and you may disagree with this. For me, there's one treatment for hook of the hamate fractures. It is excision of the hook of the hamate. It would be super rare in maybe an elderly patient with a fall to treat them in a cast. I just don't think it's a reliable treatment because the problem is blood supply, and you're at the watershed zone where the hook meets the body, and so healing is just lousy. Fixing these makes no sense. So it's excision, and it's a very successful surgery with very low risk, but there is risk, and the risk is the nerve. And so Guillaume's canal release in the typical fashion, you palpate the hook of the hamate, and I try to dissect sharply with a 15 blade and excise it. It doesn't always come out easy because sometimes there's scarring, sometimes there's a partial fracture, et cetera, et cetera. So it's not always easy to get it out, and you have to take really good care of the nerve. Not that, yes, we worry about a laceration of the nerve. We also worry about stretch injury of the nerve. But how do you handle the motor branch in this situation? Do you like to identify it?
Yeah, I mean, I identify it all the time. I think that, the beauty of the surgical video education that Dr. McKinnon has used is that everybody has seen this procedure typically by the time they hit the door on rotating with us. And one of the things that she talks about is that you can't see the branch until you've released it. I kind of disagree with that. I think that if you work for it, you can find it. And my personal preference is to find it. Usually there is that kind of transverse branch heading towards the ulnar side of the palm, coming off of the ulnar artery. And you can find that branch, and that's usually where the takeoff of the nerve is going down, the zone 2 nerve. So, once I see that transverse arterial branch, then I go and find the nerve, I release it. I've only done a handful of hook excisions, to be honest with you, because it just doesn't come up in my practice that often. But I like that's the case for me. and the rest of it is me gently protecting that nerve while the other trainee or whoever I'm working with gets that fragment out. Um, I guess before, I want to hear how you take care of it, if it's any different. And then, is there any functional loss from having the hook excised? I think that's a question that patients will often ask.
No, never seen any functional loss, and certainly, while it's less common in Major League Baseball players, it still does happen. Mike Trout's out right now with a hook of the hamate fracture, or maybe he's back now, but no functional loss whatsoever. Pain goes away quickly but unpredictably. So I tell everyone 6 weeks. I do splint all of these patients for at least a couple of weeks because I've tried to not splint them, just put them in soft dressing. It's too painful. So splint for a couple of weeks, and then I'll let them ramp up as they tolerate from there, typically 5 to 6 weeks.
Okay. All right. Well, there you have it.
All right. So let's do let's shift gears a little bit and have a fun conversation about how to say no.
Yeah, so I think that it's timely for you since you've obviously made a big decision to go back to school and Billy Madison style. I guess many of our listeners won't understand that reference, but so you're starting business school shortly, which is a big decision. I meet with some of our former fellows on a regular basis to do kind of mentoring sessions. So I was meeting with one of them recently who's in academics, and they were mentioning just that they are overwhelmed right now with all the different things in terms of their clinical activities, both elective stuff and then call stuff, as well as trying to get research stuff off the ground, and continuing and just kind of drowning in everything. And their question was, how do I prioritize things? How do I say no to things? So I was thinking about that, and I think I gave them my response in terms of how to evaluate opportunities and what to do and what to say no to, how to say no. But I guess I wanted your sense on at earlier in your career, when you were in kind of your reputation building phase, how did you balance kind of this busy clinical practice with not needing, but maybe wanting to develop your reputation, maintain good relationships with your colleagues in terms of not always saying no to stuff? How did you handle that?
It's a really important concept, and I think it's very different today than it was 20 years ago. I had very dogmatic advice, handled differently from a couple of my mentors. They all said it, they all had the same message, they all said it differently. The bottom line is you just say yes. You say yes to everything, and you do things well. You prove your value to people across the country. They could count on you to write a chapter, write it well, and get it done on time. And if you do that, and more opportunities follow. I think there probably were fewer opportunities then. Now there's so many different directions one can go, whether it's primary research, whether it's multi-institutional research, whether it's videos or podcast or chapters or speaking engagements. I don't know if that's accurate or not. It feels like there's so much more variety and more opportunity that you're probably getting hit from more direction. You think that's true?
I think that's true, and I think that the relative value of these things has changed, right? So, I mean, chapters are still, they exist, but I think less people are actually reading them and using them. It's something that honestly I'll still do for a friend. Uh, and even for friends, I try to get out of it, to be honest with you. Um, but and I'm guilty of currently editing a book and asking people to write chapters. So, but I think that again, it depends on where you are. I mean, I think the value of chapters from a academic, true promotional type perspective is very little, but it is more of, I think, of just relationships and networks and trying not to upset people by saying no, and if you're going to say yes, doing a good job. I don't know. I think I try to follow kind of the adage that you read, about, if you're going to say no, provide somebody who can perhaps, fill in or sub or something like that. But it doesn't always work out. And I think you have to be careful about who you say no to, because that might be not necessarily a bridge burned, but some people have, long memories. Other people don't care and don't remember.
Yeah, I think that's right. I think you said a number of really important things. So first of all, who's asking? And when you're younger, if you take the Hand Society as an example, and there's a VIP in the Hand Society who's going to be around for a while and asks you to write something, A, you should be flattered, and B, it is an opportunity to prove yourself. And some people, although less and less, I think, will be offended if you say no. Now, that person may not reach out to you again, but most people understand that we're all trying to achieve better work life balance than perhaps was such a focus, wasn't much of a focus 20 years ago. I don't know. I still think as you're really getting started, and you're trying to create relationships, this is one good way to do it, but you do have to do it carefully.
Right. The last thing you want to do is say yes to something and be late to not do a good job, and then it's just you've lost on all accounts.
Yeah, here's a good tangential story which really had an impact on me. So I run a local board for the World Pediatric Project, which has been a really great experience. It's a little bit of a time suck, but not a major one. And we were trying to attract new board members, and we had this really great guy that we were all excited about. He had been vetted by our membership committee and was all in. And then he was asked to participate in something different, which was more meaningful for him, and he decided to go with the other opportunity. Totally understandable. I walked away more impressed with him than I ever could have been had he joined our board because of the way he said no. And he wrote a thoughtful, I think he had a verbal conversation with the person he was most connected with, but he wrote a really thoughtful email explaining his decision, apologizing for his decision. And I just walked away thinking, wow, this guy is impressive, and what a bummer. Maybe in the future we can come back to him.
It goes to show you. I mean, there's so many quote soft skills that we never, most of us never get a formal education in, at least in kind of the medical training. And maybe this is the stuff you're gonna, the touch and the polish you're gonna learn at business school. But I think some people just have it, other people don't. And it's not certainly something you can learn to do. It's just having the ability to to have to understand how your actions come across and how you can control or modulate that. And not to be overly manipulative, but certainly there are ways in which you can say things and frame things that will come across better than other ways.
Yeah, for me, what I'm curious how you handle the saying no now. I do think it needs to be heartfelt. Obviously, it needs to be honest, but the real issue for most of us is just time. And if you can honestly say that you're overextended, you don't think you can do as good a job as you otherwise would like, you don't think you can hit the deadline, I think that will resonate with the person who is requesting. I would say the danger about the deadline is if that's your only excuse, they may say, "Oh, we can be a little soft on the deadline," and then you're hooked. Then you can't get out of it.
I've I've tried to say no to stuff recently and use all the tricks and have been looped back in on all of them. So, at some point I just kind of gave up and just added it to the list, unfortunately. So, those of you, there are a couple of friends of mine that are listening that probably know what I'm talking about, and I'll leave it at that. But anyway, this was fun. Hopefully this grab bag of things was fun and useful. And if you made it this far, thanks for listening.
Yeah, it's fun. Absolutely. These are great topics, and we need to really hit an HBR article in the near future, but fun to touch on it as I'm getting excited about going back to school.
All right, and we'll have to hear more about that as you go through this journey.
All right. Have a good day.
You too.